will hear from a proponent and an opponent on this issue. Today we have Kim Malsam-Rysdon, who's Vice President of Public Policy for Avera Health. Welcome, Kim. And we also have Lisa Nolan, Coalition's Director for Americans for Prosperity. Welcome, Lisa. Thank you so much for being with us. Before we get started, I want to go over a few housekeeping items. For those of you who are in as participants, you'll notice you're not able to unmute yourself or turn on your camera because I'm a so-so moderator. I couldn't moderate all 30 of us talking at the same time. If you have questions, we absolutely do want to hear them, but I would ask that you please submit them through the chat box. And all of those chats that are submitted will be viewable to me and my team. And we'll have that team, look for duplicates, etc. And then I'll share those questions both with Kim and with Lisa. I want to start by having Kim share the proponent side, and she'll have 15 minutes to do that. Following that, we're going to let Lisa present the opponent side, and then each of them will also get 5 minutes rebuttal time to bring any counterpoints that they want to what the other shared initially. Following that, I'm going to move us into some Q&A because we do want this to be as informative and educational as possible. And my goal is to manage the first part of this so that we have about 20 minutes left for Q&A at the end. So now that I've got all that out on the table, Kim, I'd like to turn it over to you, and we'll go ahead and start your time now for 15 minutes presenting the proponent perspective on this issue. Thank you, Kim.
Great, thank you. Shon, I can see you, so can you see my screen and can you hear me? Awesome. Well, thank you, everybody. It's a real pleasure to be visiting with you today, and I just wanted to share a few slides that kind of outline some of the data and specifics around Medicaid expansion in South Dakota, what it means for South Dakotans, and then really hope to engage in conversation and questions, as Shon indicated. So the first thing is, what is Medicaid? So Medicaid is a federal and state funded program that provides healthcare coverage to people who meet certain eligibility requirements. Today in South Dakota, those groups that are covered by Medicaid are very low income families, pregnant women, children, and then elderly, blind, and disabled adults. Today on Medicaid, we know that 54% of the population works full-time and 11% of the population works part-time. Medicaid expansion would provide healthcare coverage, again, not cash payments. That's how Medicaid works today. That's how it would work if we expanded Medicaid. But we would extend that eligibility to adults age 19 through 64 with income levels up to 138% of the federal poverty level. And so what this does is it really helps people that are caught in the middle today. Just like the existing Medicaid population, the majority of this population with the expansion group is working, but they're really caught in the middle. They make too much to qualify for Medicaid today, but not enough to go to the exchange and get subsidies for an Obamacare plan. And so Medicaid expansion would extend healthcare coverage to them. And just so you can see on the slide there that we're talking about folks with, with low incomes. These are individuals making, I think it's been updated to maybe less than $19,000 a year, but families of 4 making less than $37,000 per year. The way Medicaid expansion works in terms of the payment is that the federal government would pay 90% of the costs. And so that's, obviously the vast majority. And then for the states that have not yet expanded, there's an additional temporary 5% incentive for those new expansion states. What that means, I'm going to just kind of get to the last bullet there, is that for the first 5 years in total, the total state cost for Medicaid expansion is $3.8 million. And then after that 5-year mark, it's estimated to be about $22 million. These numbers, you can see the sources there. Those come from the Legislative Research Council, and I know Alan Solano is part of the presentation today. He would tell you that group is the nonpartisan staff that professional staff that work on behalf of the legislature. So this comes from their fiscal note. This is actually a table of what the LRC put together. And I think what this really illustrates is that, the federal government is really investing in Medicaid expansion in states to a very high degree. Again, over the first 5 years, it only costs the state of South Dakota $3.8 million. Now, some people say, well, what about the $22 million and how would we actually afford that? I think it's important to, first of all, remember that last year, when we ended the state fiscal year, we had $115 million in additional revenues and less expenses. So we had a budget surplus of $115 million last year that we put into reserves. The year before that, it was $85 million. And in the 10 years prior to those 2 years, the average was over $18 million per year. So I think it's safe to say that we can afford Medicaid expansion with our current general fund budget, and we can afford it without raising taxes. The other thing that I want to point out about this slide is, again, you see the federal dollars that are a significant part of how expansion is paid for. Today, we are essentially funding expansion in other states because our federal tax dollars are being used in states like California and New York to fund expansion there. If we expand Medicaid in South Dakota, we would be keeping over $300 million of our federal tax dollars here in South Dakota to support healthcare for our population. 38 other states have expanded, 39 if you count DC. And so the benefit of that is that we really have there's been over 600 studies done on kind of the impact of Medicaid expansion, what's happened in different areas. And so we do have that benefit. One of the things that's really important to remember is that folks that are part of the expansion population work more, and I'll get into more about that in just a minute. So who does Medicaid expansion help? It helps the people that would be covered by the service and get healthcare coverage. It protects rural healthcare, and it really helps small businesses. So in terms of the population itself, what we know, and this is really borne out by the studies of Medicaid expansion where that's happened, but also in a more general sense about what happens when people have healthcare coverage versus being uninsured. We know that they're more likely to get preventive care. We know that they're less likely to use the ER for regular care. We know that they see better health outcomes, and that kind of runs the gamut. It's everything from getting primary care, taking care of small problems before they become larger problems. It includes chronic care management at a higher degree for things like diabetes and heart disease. It also has to do with cancer screenings. And so in South Dakota, we know that people who have healthcare coverage are twice as likely to get breast cancer screenings than those who don't have coverage. And people are 3 times as likely to get colorectal cancer screenings if they have health coverage. We know also that folks that are in the expansion population who get coverage are healthier and they're able to work more, not less. That's been borne out in several studies that have happened since we've seen expansion available to states in the last 10 years. This actually shows a little bit about where people are in fact working. This is a national slide. And so what we know in South Dakota is that at least 60% of the expansion population is working, and they work in, industries that you might expect, recreational, tourism, construction, more seasonal kinds of things, and then retail are really kind of those big industries that you would see the covered population working in. We also know that those employers have a hard time offering insurance. And so I think that's kind of intuitive as well. So these are folks that can't get insurance through the exchange. They don't. The law requires that people that can get subsidies through the exchange or Obamacare have to make at least 100% of the federal poverty level. So we have that group that's in the middle. It's also interesting that Medicaid is actually cheaper for the federal government than subsidies on the exchange. And so if you're concerned about the federal deficit, Medicaid expansion is actually cheaper in the long run. The second point is that expansion really helps rural healthcare. And so, we know that people that live in rural areas are more likely to be uninsured. And so what Medicaid expansion does is it helps that group in particular have better access to preventive care so that, again, they're taking care of small problems before they become big problems. It also helps rural hospitals have less uncompensated care. So it makes them more fiscally viable so that they can serve everybody in their community, including the expansion population. Medicaid expansion helps small businesses. Again, the majority of the population is working. And we know that, business owners want to be able to provide insurance, but it's very expensive. And so they just, aren't always able to do that. We think that expansion will help us with workforce recruitment and competition with neighboring states. We've seen all states except Wyoming, as I showed you on that map, expand Medicaid up to now. People have asked, in fact, some folks from Elevate in particular have asked about the impacts on health insurance. And so what we've been able to see is that states that have expanded Medicaid do see an impact on their health insurance marketplace premiums. And I think that makes sense because what we see is that as we have more people covered with insurance, the state's risk adjustments actually are reduced, and we see lower premiums as a result. And so looking at the 2015 to 2018 data, we see premiums that are 11 to 12% lower in states that have expanded Medicaid compared to states that have not. This is a slide from the Kaiser Family Foundation. If you're really into kind of what the research shows, I would point you to that resource. Again, they've looked at over 600 studies on the impacts of Medicaid expansion. And this is a slide that they put out on really kind of those impacts of economic measures. The green bar shows the positive studies, and the blue bar shows studies that did not find a difference and did not find a negative impact. And so had there been a negative impact shown by any research on effects on state economy, uncompensated care costs, financial performance of providers, employment, or other state costs, you would see an orange bar. And I think it's noteworthy to see that there haven't been any negative impact studies found as a result of Medicaid expansion on these economic measures for states. There's a couple of arguments out there about other things that we should be doing outside of Medicaid expansion to address things like high healthcare costs. And, we're, really grateful to see innovation in healthcare, and we've seen a lot of innovation. But the fact of the matter is that these kind of market kinds of strategies just don't work for people that are at the income levels that would qualify for Medicaid expansion. So increasing, supply of healthcare through technology is a great thing. We're seeing a lot of innovation in that space. But again, if you don't have coverage, you're also likely to have the, private resources to be able to afford those things. And so, Walgreens and CVS and kind of market innovation from non-typical providers, again, a great thing for healthcare. But if you don't have coverage, you just can't afford those things. Health savings accounts, they're tax-free tools. Again, remember who we're covering with expansion. They just don't have the income to invest into HSAs when they're trying to put food on the table and keep a roof over their heads. So with that, we really appreciate the support of Elevate Rapid City. I know that there was we provided a lot of different information, and I know that group really carefully looked at the different factors associated with Amendment D. We appreciate Elevate's support, and we hope all of you will go to the ballot and vote yes on Amendment D on November 8th, or vote early if that's available to you. So thank you for that. I look forward to your questions.
Thank you very much, Kim. Next, I'm going to turn it over to Lisa Nolan. Again, she's the Coalition's Director for Americans for Prosperity. And Lisa, feel free to jump in. You've got 15 minutes.
All right, thank you. And we'll work on video if we can do that here. Thank you very much for having us as well. I appreciate that. My name is Lisa Nolan. I'm with Americans for Prosperity here in South Dakota, the Coalition's Director. with Americans for Prosperity. Can you hear me okay, Shon? Okay. So with Americans for Prosperity, we have a strong belief in people. And we think if we remove barriers to innovation, to the amazing things that people are doing, we can have some really good outcomes in our society. But, particularly with healthcare, we see a lot of those happening. We think that South Dakotans, every South Dakotan deserves greater access to quality care and that it should be affordable for them. We may disagree on how we get to that place, and we'll talk about the reasons why, but I do appreciate that we all have that shared goal of wanting to have good health care for South Dakotans. One of the things you'll need to do when you get to the ballot, you'll be thinking through your decision. Maybe you've already decided, maybe you're thinking through it when you get there. But I would encourage you to just ask yourself 3 questions before you get to answering that main question. The first question you want to ask is, do we want to help more people get back to work? Or do we want more people sidelined by more government, more welfare? What we see is that with Medicaid expansion, sometimes people are interpreting that as expanded benefits for the people that are already in that safety net, disabled, elderly, kids. But actually, it's expanding that to able-bodied working age individuals. So people who are able to work and they want to do that. We think these are hardworking South Dakotans that want to be doing that. What we see is that the timing really couldn't be worse. When we looked at other states, there are studies that show that placing able-bodied individuals on Medicaid causes an overall decline of employment by 3%. I'll put the links to those studies. I'll send that out in a 1-pager following, so you can go back and look where that is coming from. And when we look at South Dakota facing a worker shortage, it's increased by 29,000 openings just between October 2021, April 2022. And what we see is that an increased labor shortage through Medicaid expansion would cause greater problems, like higher inflation, smaller incomes, more taxes, and a broken economy. When we're talking through that, we do want to reiterate, these are hardworking South Dakotans that would be incentivized to have that income below the 138% to continue receiving benefits. And we want to incentivize South Dakotans to be able to get back on their feet. The second question I would have you ask yourself is, do you want to remove about 17,000 South Dakotans from their current private health insurance and shift them on to Medicaid? So prior to COVID, there were already plans on the exchange available for purchase. And that would go anywhere from 100 to 400% of the poverty level. Under the current federal law, through ARPA, the federal government decided for lower income South Dakotans and any states where they've expanded Medicaid or where they have not expanded Medicaid, where they've resisted, then they get federally funded silver level private plans at no cost to them. So anywhere from 100% to 150% of the poverty level has a option right now that the federal government is a program that they're doing that already has been extended another 3 years. When we talk through that, we're not necessarily saying we advocate for more spending at the federal government and the state level government, but that program is happening. And so even if you agreed with Medicaid expansion, that would be the worst time to put that in place. As soon as we would shift over to Medicare to expanded Medicaid, those benefits would be removed. These low-income South Dakotans would no longer get the federal subsidy. They would no longer have the private health insurance. That health insurance is a better plan for them in terms of the services that they get, and it's a higher payment for the hospitals. And so right now with that in place, we would not want to shift all of those South Dakotans that are on the plan or could be, and shift them onto Medicaid, where we do end up having a state-funded portion. And then rural hospitals get paid less, providers, and patients aren't getting as good of care. We want to make sure we're highlighting that. And we know that that is, again, between 100 and 150%. And then under 100%, in South Dakota, really, it's a matter of working part-time. That brings you to 100% of the poverty level. And there are also wonderful services that we can talk about as well. One of the third question I would ask you, and I think is the most important question, is do you want to prioritize able-bodied adults, or do you want to prioritize the disabled, kids, the elderly, the truly vulnerable that need the safety net? South Dakota has actually done a very good job of protecting the safety net that we have in place for those truly vulnerable communities. Again, that's the elderly, that's disabled, that's children. These are people that are not able to, they're in the most vulnerable state and they're not able to do this for themselves. And so we prioritize those resources and we protect the safety net in a few ways. One of them is by having what you find in states that have expanded, and what we don't have here yet, is a crowding out of some of the services. We already know it's difficult to find mental health providers in South Dakota. If you add another 44,000 people to our Medicaid rolls, and that's been a low estimate in other states, the average that's at that enrollee estimate was actually doubled with an actual. So you're talking with having that many more people accessing the same services, you're crowding out the resources for those that truly need that. So the question we have to ask ourselves is, who do we want at the front of that line to receive that care? When we look at waiting lists in South Dakota, we do not have any waiting lists. When we look at, for example, home-based healthcare, spina bifida, these are optional in South Dakota. Many other states put people on waiting lists for this, but we have 0 people on the waiting list for these services today. So nobody has to wait, nobody on Medicaid currently has to wait in line for home-based healthcare. This provides families a lot of security and certainty, but you can look at other states that have waiting lists in the thousands. There are 22,000 people that have already died on Medicaid rolls on waiting lists. And so we want to make sure that we're getting this service to those critical populations. One of the other ways that we have done a good job in South Dakota as well is we have protected against fraud, waste, and abuse. And that means a couple of things. One is that it prioritizes the benefits and puts them in the right direction. It provides those benefits to the South Dakotans who truly need those. If we have more fraud, waste, and abuse with an expanded Medicaid, we already see it in the current. We already see that there is that fraud, waste, and abuse. And right now, the way that Biden has the strings on Medicaid expansion is we can't set any work requirements. We aren't able to do any sort of waivers. And that is something that's been very helpful. Well, this is a more one-size-fits-all, and it's federal government having more control in our healthcare. But we do, in South Dakota, have options that would tailor the program to South Dakota and that already have. Unfortunately, right now, 2 things will happen there is the federal government is, the Biden administration specifically has said that we cannot put those provisions in place at this time while we're in the state of emergency. Furthermore, by putting this into the Constitution, it specifically states that we can't add more requirements on this population of Medicaid patients that are on the others. So we don't have a lot of room to tailor this program to our state. And that's really important in order to prioritize the dollars where they need to be. So that third point there is I would just encourage you to think about how are we protecting the safety net? In other states, financially, what we've seen is that I mentioned they've been double the enrollees on average. We see waiting lists in other states. We see busted budgets where people, if this goes through in South Dakota, there are tough decisions that we would need to be making. Right now, we spend about 20% of our budget on Medicaid expansion. Other states like Ohio have, or on Medicaid, I'm sorry. Other states like Ohio have seen that go from 15% to 25% of their budget. Florida right now, a third of their state budget goes to Medicaid. And so while these numbers that we're looking at here, they do still show we're going to have to come up with some money. We also need to, that would take a lot of faith in the federal government to assume that that deal is never going to change down the road. We've seen it enough times. We've seen that programs get extended, that we're not able to roll back what's there, and that the federal government will pull back on the promises that they've made. We've seen that across South Dakota as well. So that when you're looking at how can we bring about greater change, greater access to better care. Kim, I'm glad actually that Kim mentioned those examples there, because there is a good, very good playbook and very exciting innovation. The things that are happening right now in healthcare, they're definitely helping people, and they're definitely affordable. Because you're not saying that people in that range can't afford anything at all. And what you're also doing is you're bringing the cost of healthcare down for everybody in South Dakota. So if you are sitting at 140% of the poverty level, you'd still be sitting just above Medicaid expansion, but we would see the cost of healthcare rising. It has continued to do. And so when we start looking at looking at reforms, we're able to bring the cost down for South Dakotans at 140%, 150% of the poverty level. And that's what we should be looking at as a long-term goal. What we know is that patients, nurses, doctors, they want more choice and control. They want to be able to make those decisions that are best for themselves. Doctors and nurses want to be able to operate across state lines. They want to operate within their full scope of training. We want access to fast and easy telehealth and expanded HSA accounts. Those actually have been a huge help to people. And specifically in South Dakota, we have another option too. The Farm Bureau has put together coverage where they can offer very, very good coverage to agricultural families, to rural South Dakotans. This is an option for them to have very good insurance through this private plan through the South Dakota Farm Bureau, which I'd encourage you to go and check out. They've been a good partner on talking about Medicaid expansion because they've been part of the solution to offer some additional options. So I just encourage you again, having those three thoughts in mind, or having those three main points in mind, that you'd be able to go to the ballot with confidence in November and just cast an issue or vote on the issue of Medicaid expansion. We think by voting no, voters will keep the door open to workable solutions without enshrining a failed program in our Constitution. Appreciate your time, and I look forward to the discussion and questions.
Thank you very much, Lisa, for laying that out there for us. So now, as I mentioned, we're going to have a 5-minute rebuttal period for Kim, and then I will again come back to you, Lisa, for 5 minutes on your side. So Kim, go ahead, 5-minute opportunity for rebuttal here.
All right, thank you. Good to catch up with you again, Lisa. We were just in Mitchell here last week talking through these issues. So I just want to clarify a few points. And again, it's the advantage for us in that 38 other states have expanded. So we know what's happened in those states. Relative to the status of people working, Medicaid expansion, and I showed you that on that slide, from looking at 600 different studies of the impacts of Medicaid expansion, we see people working more and not less. And so that's a great thing. That helps us use our current limited workforce to a higher degree, which is one strategy that can help us with that broader workforce issue. Let's make sure the folks that we do have in the workforce are working as much as possible. The issue about crowd out and what happens, to people that are currently on Medicaid. The thing with that is that's really an apples and oranges kind of comparison, in that people with disabilities getting home and community-based services are already on Medicaid, and those providers are providing specialty services that the expansion population in and of itself would not be accessing. Because if the expansion population needed those services today, they would already qualify. So we don't anticipate crowd out. The waiting list issue is regarding those other specialty services, which just don't relate to the expansion population. In fact, South Dakota has one of the highest participation rates of primary care providers in the state actually participating in Medicaid. And I think it's noteworthy that the South Dakota State Medical Association, which is the association of physicians across the state, as well as the Association of Nurse Practitioners, the Association of Physician Assistants, all support Medicaid expansion because they know it's good for their patients and it helps them get preventive care, and they are ready to serve that population. Fraud, waste, and abuse. There's been no study that shows that Medicaid expansion contributes, to that issue. That issue is out there. South Dakota does have a very good track record. We run a tight ship in South Dakota, and I'm very proud to say that we have not seen, the scandals that we've maybe seen in other states, but that again is not an issue specific to expansion. Medicaid's been in place as a federal state partnership since 1965. That's, longer than many of us have, been alive. And so the federal government has not backed out of its commitment to partner with states on Medicaid. The funding percentage for the expansion population, so that 90% that the feds would fund is in law. And so there would have to be a federal law change to ever see that change. And with 38 other states already participating in that, that's a very unlikely prospect. We haven't even seen a bill introduced federally to change that because it's been, in place now for over 10 years. The last thing I would leave you with is that, Amendment D is supported by health systems. It's supported by the Medical Association, religious organizations, the state chamber, Elevate Rapid City, the Sioux Falls Chamber, AARP, the Municipal League, the Farmers Bureau, which would continue to offer its own insurance product, and people could choose that if they wanted. I think it's got the support of people because it makes sense for South Dakota, and I hope you'll agree and vote yes on Amendment D. Thank you.
Thank you, Kim. And now, Lisa, I want to turn it back over to you for an opportunity for a 5-minute rebuttal.
Yeah, thank you. I appreciate that. One of the first things I had here with the, when we're talking through the expanded program, and we're talking about fraud, waste, and abuse, it's not that these are scandals that are happening all over or big scandals. It's just a nature of government. It just, there is, it's not the most efficient way that we're doing things. There is fraud, waste, and abuse, and that may come in the form of simply right now, enrollees, even if they're making more than what they would to qualify, you're not allowed to remove anybody from Medicaid expansion at this time. This is part of the federal government. But we've seen as much fraud overall in the program of Medicaid. If you covered all of the fraud, the cost of that is actually more than 37 out of our states combined spend on healthcare total. And it's just the nature of the fact if you have fraud, waste, and abuse within a program, which we know that we do, it's documented, then when we expand the program, we expand the fraud, waste, and abuse. That is along the lines when we're talking through the different numbers that we're seeing with employment as well. You're going to see different numbers in different studies. I wouldn't discredit or discount anything that Kim's showing, and I think vice versa, in terms of we've got a study that we're pointing at with a 3% decline in employment. She's looking at studies that don't show any change in employment. So when we're looking at the different studies and we're talking through those, I would just ask you to keep in mind too, kind of where when you think logically or think kind of common sense why employment might go down if you have people on a program that is in place, as long as you're stay under a certain level of income. It's important to be able to think through that and what you've seen in the past when you're thinking of programs that come in from the government. So it's logical, because we've seen it before, that federal government rolls back what they say they're going to do. With Medicaid expansion in other states, they were able to initially put on work requirements. And during this crisis, this emergency crisis, even though that would have been in statute, the federal government was able to say, we're going to roll back your work requirements. Even though you've put them in place in your states, we're going to pull them back and say you need to offer those benefits. It's written there in statute that people are only qualifying under the 138%, but we know they've declared an emergency, and the federal government has decided that even if they fall off of the eligibility for Medicaid, that they would continue to stay on until this emergency is over. So it's been common. We've seen that promised in health care from the federal government across South Dakota over and over. And we've seen the federal government pull back on what they say they're going to offer. Medicaid expansion is being offered now as a replacement for other failed programs that they haven't committed to over the years. And so we would count on that funding to stay there if we saw that on a regular basis. So I just keep that in mind as you're thinking through those conversations. And also when you're talking through, with that when I mentioned the South Dakota Farm Bureau as a coalition partner, that they're in place specifically because of the plans that they offer. And they look forward to being able to offer those to families. Appreciate that. Hope that clears up a little bit there as well.
Thank you, Lisa. And I want to say thanks to both Kim and Lisa for keeping us right on time. The good news is we have now a full 20 minutes available for Q&A. So I would encourage you guys once again, use the chat function, please. I've got a team of folks working to capture those and bring me questions. I've got the first couple here, and I'm gonna start with a question about interaction of Medicaid, Medicare expansion with IHS. Lisa, since Kim got to go first initially, I'm gonna give you the first opportunity, if you'd like it, to respond to this, and then Kim, I'll come to you. So the question is, how does this expansion interact with IHS and the services covered by IHS?
I want to make sure I'm speaking to that just within my knowledge base. So I think you'd be able to get a fuller, more detailed answer elsewhere. But what I will say is that I believe Medicaid expansion, I shouldn't say I believe, but Medicaid expansion is this program that's being offered due to the failures within IHS, the failures to fund IHS. I know that currently, and what I've heard before in talking with folks around Medicaid expansion in terms of tribal populations, is that IHS, and I used to work with them myself in a previous role, runs out of money about 6 months into the year. They can't take care of the people that they are tasked to help. They are stretched. They're not getting the funding that they need. They're frustrated. And so because of the failure of the federal government to fully fund IHS is one of the big drivers of people wanting to go over to expanded Medicaid. And I've heard this presented multiple times in forums that we're covering a significant portion of healthcare within the tribal communities, and that if we move everybody onto Medicaid expansion, it will alleviate that load for us. Now, there's a relationship I see that happens with Medicaid coming in to try and cover for IHS.
Okay, Thank you, Lisa. Kim, do you want me to repeat the question or are you good?
No, I think I'm good. Thank you. And thank you for that question. It's really, really important. So a couple of things there. First of all of the tribes in South Dakota are on board with Amendment D. And that is because they do see the fact that Medicaid expansion would help IHS. And so much of what Lisa said there is accurate. IHS is underfunded. And so what Medicaid expansion brings to the table is it brings more people that are currently uninsured who would then have healthcare coverage in the future. And IHS as a provider would be able to accept Medicaid payments when they're providing those services to that population. So it increases revenue for IHS that they can then reinvest into other services that they can't fund today. Now, the interesting thing about IHS is that when a person on Medicaid goes to IHS, and that this is today, as well as if we expand Medicaid, okay? So today, if a person goes to IHS and they have Medicaid, and IHS provides that service and they bill Medicaid, the federal government actually pays 100% of that bill. And that is part of the treaty relationship that IHS and tribes have with the federal government. And so what's important about that is that those expenditures, the fact that those would be paid 100% with federal funds, are not part of the state estimates. And that's why we feel confident that the state estimates of the cost for Medicaid expansion are actually higher than what they'll come in to be, because anybody using an IHS provider, as one example, would be paid at 100% federal funding. So a little bit of wonkery there, but definitely expansion helps IHS because they'd see more people with health coverage.
Okay. And then for this next question, I'm going to go in reverse order. So Kim, I'm going to give this to you first, and then Lisa will come to you after Kim gets a couple of minute whack at this. So the second question is, how does the use of emergency services impact the cost of healthcare, and how does improved access address that issue?
Yeah, I mean, that's really kind of getting to a core reason why so many groups support Amendment D, especially healthcare organizations. So, if a person does not get preventative care and lets a small problem become a big problem, and they come to the emergency room, we're going to treat them. They're likely to not be able to follow up with what they need to do to stay healthy or get healthy, and end up in the emergency room again. And so that's another part of the research that we've seen as a result of expanding Medicaid, is that we see people in the expansion population use the ER less for just regular care, because they get access to preventive care and primary care because they have health insurance coverage. So what happens when people use the ER is that that's the most expensive way to provide acute care. And so those costs then get spread to all of the other payers to make up the difference when people come and don't have healthcare coverage. That's why it's important that we look at, what happens to health insurance rates in states that expand. And we've seen those rates actually reduce in those states that have expanded because, again, people have coverage. It's not all falling to those private health plans.
Okay, thank you, Kim. Lisa, would you like me to repeat the question, or are you good?
I always use a repeated question. That'd be great.
Okay. So the question is, how does the use of emergency services impact the cost of healthcare, and how would improved access affect that issue?
Perfect. Okay, thank you. There's just 3 points I would make there. One is I mentioned the federal subsidies right now. So we actually have better private plans available, better payments to providers, rural providers, hospitals, independent providers. So we're actually sitting in a better spot right now as a non-expansion state in terms of the benefits the patients get and the benefits the hospitals get than if we were to go to expansion. We will lose those. And again, the information, I would 100% say the information should be out there more on those private level plans, on those private silver level plans. But for those that have them, they are incredibly helpful. We've heard many testimonies of folks that have signed up for that and have good coverage. And so that specifically, with that being in place right now, is, I believe, if you're looking for something that will keep people out of emergency rooms and seeing providers more, primary care providers, you're actually going to receive better benefits with less out-of-pocket expenses. Again, not advocating, but telling you that's what's available right now on the federal government subsidies that they're already doing. The other thing that I would want to mention in there is there are some really great options around that I would very excited to, that I've talked to some different providers over the last year or two, and one model is called direct primary care. Direct primary care specifically is a model of care, pretty much cuts out the insurance, cuts out the government control, and allows a person to work directly with their doctors. One of the best patient-doctor relationships you can have. The doctor talks with you for 45 minutes instead of 5 minutes with 40 minutes of paperwork. And what they are able to offer people outcompetes Medicaid, and it does not send people to the emergency room. A lot of times people are going to the emergency room and they need medications. And with direct primary care, you can actually do wholesale medications directly from the primary care provider's office. So the concern is valid that we don't want people rushing to the emergency room, but there are far better solutions. One that's in place right now and available, and one that people can move more towards, which is the direct primary care. And then the third point I would mention is just in North Dakota, I would press to give you an exact number. And so I will see if I can follow up with you on that and getting that out. But from personal experience as somebody that worked with the Medicaid program in North Dakota, people saw themselves as having coverage. They still weren't going to their primary care providers, but they were feeling more comfortable about going to the emergency department. And so I would, again, follow up with numbers and what that looks like and how that's changed. But I do know that it hasn't solved the issue of people going to the emergency room in North Dakota to expand. Thank you very much.
Thank you, Lisa. And I do have a follow-up here that I want to just try to clarify with both of you, because frankly, I wasn't personally familiar with some of what you mentioned, Lisa, but you talked about those, those federally funded silver plans. I think I heard you say that that's for the 100% of FPL and over. Is that correct?
Yeah, so it was open up to 400%. Right now, what they did is from 100 to 150%, which includes, Medicaid expansion goes up to 138. So a significant portion there is zero premiums right now for these private level or silver level plans. And they also have reduced, so there's no out-of-pocket expenses. So anywhere up to 150, from 100 to 150 is zero out-of-pocket, zero premium. It's significantly reduced, and when I say reduced, I mean subsidized, the amount of that a person gets between 150% and 400% as well. And then they've offered the exchange to people above 400.
And part of what I wanted to clarify, Kim, I wanted to come back to you because, and again, forgive me, I don't work in the insurance industry. So, and I'm guessing a lot of people, I recognize some of these names, I'm guessing a lot of people may have the same question, but when we think about expansion, Kim, talk to us a little bit about the levels relative to FPL that this covers and where you believe a gap might be there.
Sure. So again, expansion would cover any adult between 19 and 64 up to 138% of the federal poverty level. And that's in federal law. So that's where that comes from. Right now, the vast majority of that group are not eligible for subsidies on the exchange because they don't hit that 100% FPL mark. And so that's the reality that we're dealing with, is that we have a significant group of South Dakotans, majority of whom are working, who are just caught in the middle. They can't afford health insurance. They can't afford direct primary care. They're just trying to keep roofs over their heads and food on the table. And they don't have insurance through their employer. And so expansion does go all the way up to 138. But for the folks between 100 and 138 today, their coverage is, if you have anybody in the insurance realm that's on this call, they would know this. They're actuarially equivalent because Medicaid has to provide a silver level benefit plan as well. So individuals who would move from a fully subsidized plan on the exchange to Medicaid would not see a change in the services that they're able to access. And again, we know in South Dakota that providers participate in Medicaid, so they would still have access to the providers that they see today. And the reason, rural hospitals and healthcare providers across the state support expansion is because we see that large group who just don't have any options today. And those are the people that, use the ER more, don't get care early, have worse health as a result of that.
Thank you both for that clarification. For my next question, Lisa, just a heads up, I'm going to come to you first on this one, or give you the first opportunity on this one. The question is, South Dakota and the Black Hills are more rural than some of the other states that were referenced relative to states that have expanded. What are the benefits and or challenges specific to Western South Dakota as it would relate to expansion?
I like that a lot. Thank you. That's one of the things we like to talk about probably the most, because we're South Dakota and we're largely rural. And so we'll go bad news, good news. The bad news is what we've seen in other states. This is statistics and the numbers show, and studies have shown that hospitals close at a faster rate in non-expansion states than in expansion states than in non-expansion states. So we have a better success rate for hospitals, and including rural settings. Within the rural programs, one of the things that Kim was just saying there too, and thank you for that breakdown there. Also, the payment to the provider is still going to be lower on Medicaid, and that they're going to get more from the private plans that people are on. Now that includes the private plans that are out there right now that we're talking about on the federal subsidy, or on the exchange with the federal subsidies. But we're also looking at people, and when we talk about small businesses, some small businesses do have insurance that they're offering, and we want to empower them. We want them to be able to continue. And so people are going to fall off, or employers aren't going to be offering the same plans when you have everybody that is qualifying, so many people qualifying for Medicaid. It does impact the availabilities. That directly impacts rural South Dakota. Again, there's people that are looking for some really good solutions, especially in the ag community. I know I've thrown the South Dakota Farm Bureau at you a couple of times. I think that's been very helpful, and that specifically is looking at healthcare in rural South Dakota. One of the biggest impacts that we've seen is that we potentially would see is when payments are lower because patients are on Medicaid that were on private plans. When that happens and we see that lowered, then the providers have a difficult decision to make. And specifically, we're talking with a provider up in, I believe it's in Faith right now, in Faith. That is, she's either got to get to a point where she can't, take those payments anymore, and she can't continue to operate with an expanded Medicaid population, or she would stop taking expansion, or she would stop taking Medicaid patients. And unfortunately, we've also seen that impact across states that have expanded, that doctors have started to opt out of taking Medicaid patients in. That also lowers the services, and it lowers the health of rural communities as well. Specifically, things that you can do better, we're talking about rural health, is allowing better scope of practice. And one quick example would be CRNA, Certified Registered Nurse Anesthetist. Nurse anesthetists had to fight to be able to operate within their education and training. And in the meantime, while they were doing that, There was a provider that shared her story that she needed to move away from her hometown where she provided services, and she needed to move out to Rapid City. Her patients are on a four-month waiting list with lower healthcare outcomes because she had to move, and she had to move because she didn't have access to nurse anesthetist anesthesiology services that she needed to. Once we saw that open up, we should see that improve in rural South Dakota. Thanks, Shon. Go ahead.
Thank you, Lisa. Appreciate your answer there. And Kim, do you want me to run that question by you one more time, or are you good?
No, I think we'll just go into it. So
Okay.
the rural impact of Medicaid expansion is, one of the reasons to support Amendment D. First of all, we know that people that live in rural areas are more likely to be uninsured. And so then this gives them coverage, which we know increases access to preventive care, management of chronic diseases, higher rates of cancer screening. The research behind the better health outcomes of people going from uninsured to having health coverage are just really indisputable. I think that's why you see rural providers, including rural hospitals, supporting Amendment D because of the health impacts. It also helps stabilize their fiscal operations so that they do remain viable. The talking point that more hospitals have closed in states that have expanded is really a situation of correlation without causation. That's not Medicaid expansion causing that. That's a lot of other fiscal issues that are really impacting healthcare, especially rural healthcare. So the fact that rural hospitals are behind Amendment D, I think should tell you what you need to know about what it means for those providers. And again, it's important that they remain viable because they serve people, throughout their community, regardless of payer source, and including all payer sources. Back to providers that claim they might not be able to take Medicaid in the future. Those are people that probably aren't serving people that are uninsured today. But I can guarantee providers that are serving folks that don't have insurance today would gladly like to see their patients have an insurance source because, first of all, they'll be healthier, they'll be able to follow up with care, and they'll use less emergency care. And that's really what we try to see across our system. So, again, it's really a great impact to rural healthcare, and it's a reason we should support Amendment D.
Okay. Thank you, Kim. And I want to say thanks to both of you. We are right up against our 1 hour time limit here. I do want to share a couple of things with you. So first of all, thanks to everyone for joining in. This is obviously a complex issue. Hopefully Lisa and Kim have done a great job. I believe they have on helping shed some light on both sides of this. I want to encourage everyone to visit elevaterapidcity.com/vote for more educational resources on all of the topics on the ballot right now. Also, the most exciting part of this whole thing, I'm guessing if we could do a show of hands, everyone on this meeting likes coffee or beer. I see a few names. I know which one you like. You don't need to raise your hand, but when you go to that elevaterapidcity.com/vote, there is a link. If you scroll down a little bit past, check out the business toolkit first, then go down a little further and you'll see a link there. One of the coolest things I've seen in a long time in all the states I've lived in, there's an opportunity here called Vote Black Hills, where if you will click on that link and go, and all you have to do is pledge to vote. You don't have to say who you voted for, what you voted for, or anything else. You go in, you pledge to vote, and you will get a voucher for a free coffee or a free beer. And I want to give a huge shout out to Lost Cabin and Pure Bean for providing the coffee and beer to make that happen. But if those two things can't get you out to vote, I'm not sure how we can help you. Once again, thank you so much. And on behalf of Elevate Rapid City, we appreciate your engagement in the process. Let's go make South Dakota the best place it can be and elevate the region for all. Have a great day.
Thank you.